Hi, everyone. Thank you for joining us today for our grand rounds. Before we get started, I'll go ahead and introduce Dr. Arnold. Most of us know Dr. Arnold, but I'll go ahead and introduce him. Dr. Arnold is a family medicine faculty at USUS in our department. Before coming to USUS, he was a faculty at Naval Hospital, Jacksonville. He's a former submarine line officer, an underseas medical officer. He recently completed a medical editing fellowship with the American Family Physician, and he serves as a contributing editor. He has also served Naples, Italy, and the Pacific island of Guam, where he was practicing hyperbaric medicine. And he was recently promoted to captain. So congratulations. And with that, I'll hand it over to Dr. Arnold.
Oh, thank you, Winnie. Just selected, not promoted. That's for fiscal year 22. So
okay, I stand corrected.
But I really appreciate that. Good afternoon, noon, morning if you're not in this time zone. Everybody, thanks for coming. I want to talk about cancer screening, but I don't think I'm actually going to tell you any rules or even talk about any recommendations except for obliquely. What I want to do is talk about some of the numbers, the risks, the controversy, the harms, the benefits, and how bad the evidence is. So I hope this will be interesting. It is interesting for me because if you asked me before this talk, what is our best cancer screening test? I would not have known. I would have guessed. So I would like you to kind of pick that in your mind. Whatever your answer is, the best cancer screening test because it reduces the mortality from that cancer, the best cancer screening test because it's a good test and it's a common cancer and therefore it's the best total people saved, whatever you want. And at the end, you'll be able to see if you're right. I didn't put a poll anywhere because I find those somewhat annoying, or I have started to recently. So here's my objectives. I'm not going to read them to you, but basically, instead of giving you should do this and we think you should do this, we're gonna kind of go beyond the recommendations to see what the people sitting at the table of fancy people were talking about. And that helps with me, and I hope it helps with you. Here's my disclaimers. I wrote them out a little too much. I don't have conflicts of interest, although I do have this approved off work job as a editor, and that's how I saw a lot of these practice guidelines and dug into them because most of our colleagues do not like people saying, do this, you should do this, the word should, it's more of the why. I don't speak for anybody. And we're going to just go through each cancer. And the first one we're going to go through is breast cancer. I think it's interesting because breast cancer is only one of two cancer that the American Cancer Society makes their own facts and figures document, which is pretty impressive. The other one's colon cancer. They do not do it for prostate cancer. Probably one of the only cases of reverse sexism I could ever point out, but they do. But breast cancer is the most common cancer, period. It's the highest incidence. It is the most cancer survivors. You can see in women, it is 30% of cancers, so nearly a third of cancers. I think everybody's heard the statistic 1 in 8 lifetime chance. I think it's interesting to break it down by decade because it shows you some of the severity. It's not something that is only seen in older people. It actually comes in with what I'm starting to think of as younger and younger. There was a time I thought 50 to 59 was in the I'll never be that old time, no longer. And 40 to 49 is what I'd like you to look at because that's the age where it's more questionable. Should we screen or should we not? And look at that risk. 1 in 65 women who is 40 to 49 will be diagnosed with breast cancer within that decade. That's something. And the mortality for breast cancer isn't that good. Within 5 years, we will lose almost 1 in 10 women who are diagnosed with breast cancer. Within 15 years, we'll lose a fifth. So even though we all know a lot of breast cancer survivors and stuff, it is not necessarily a benign cancer. There's a real reason in this common cancer with big mortality that we want to screen if we can. And unfortunately, the mortality has a lot of racial inequities. Look at the rate in non-Hispanic Black women. The mortality rate is almost 1.5 times that of white women. We don't know why. We'll look into a couple of the reasons there, even though the incidence is lower. Probably, I will suggest that the difference in incidence is actually the overdiagnosis, the screening, finding cancers that never would have bothered people. And then the question is the high mortality rate in Black women, is that due to underdiagnosis, diagnosing too late? And unfortunately, here's the trends in breast cancer survival. And the dark red bar is just the difference between white women and Black women. And it's not very encouraging. Maybe it's going down over time, but you kind of have to squint, decide what you want, squint, and you can trust yourself. We still got miles to go. And then if you look at survival, break it down, well, everything matters by stage. If you get a local cancer, you're much better. If you get metastatic, it's much worse. And look at how dramatic the difference is here. Localized breast cancer is a very benign disease. As soon as it gets regional, as soon as it gets to lymph node, it's very different. And that's part of that mortality. And let's look at how that, how that goes with race. Look at that. If the bottom red band for each of these racial groups is the rates that are diagnosed as a local disease with a 99% survival. Look at, there's a 10% difference between, again, white women and Black women. That's an enormous finding, which has to be part of that. And that suggests that we are finding these cancers much later in Black women. So just chew on that. We've got some other stuff to show you. The other thing is the cancer markers, and those have a difference as well. So HR is the hormone receptor or estrogen receptor, and the HER2, HER2 is that HER2 with Herceptin, and I always thought of it as one of the first biologic cancer drugs we have. What it also is a marker that you can separate survival. But look at that, it's interesting that the best cancer to have is hormone receptor positive, HER2 negative. So one that Herceptin won't help at, which is interesting. And look at the difference here. Again, racial lines. This is from the American Cancer Society. The bottom red bar, again, is the best cancer to have with receptors. Look at the difference between non-Hispanic white women, non-Hispanic Black women. That I can't explain. That doesn't seem to be a later diagnosis. Look at also the top line, which is the hormone receptor negative, HER2 negative rate, that dark gray line. That's also the lowest survival, and the difference there is surprising. That does not seem to be an underdiagnosis, but I don't know how to survive it, and I didn't see anything that discussed how to survive it, how to explain it, excuse me. And this is something I made up myself. This chart is based on some data I found looking at the number of deaths per 10,000 women in each decade of life. And the sad thing is that dark red line is the number of deaths that we can prevent due to mammograms. So the problem is we can worry a lot about mammograms, but we're nibbling at the edges. In fact, let me show you. Here's the percentage of deaths at each decade that we can prevent based on our studies with regular mammograms. It's not a lot. The average is 4% of the total. So then with that, I just depressed you, I apologize. Let's look at, should we screen every 1 or 2 years? Should we screen at age 40? Should we screen at age 50? And I'm not going to tell you which to do. I don't think there's any right answer for anybody. I think it's up to the person. So the fact is, what we can do is per woman, on average, we can increase their risk, their chance of not dying from breast cancer by under 1%. And it's a little more with annual screening. You see that slight difference. Similarly, you get a slight increase in the average life years gained, which obviously that's per woman. So really, in parentheses, is the per woman who is diagnosed with cancer.
Mike, there is a question.
Yeah.
Jeff is asking, where did the mammogram death prevention chart come from?
It came from, that came from data that was in the American Cancer Society booklet. And then the prevention data came from the USPSTF paper. And then I just combined them into an Excel spreadsheet and made a chart. Great question. So we said there's a slight difference, and look at the harms for that. Now, you may not have known this. I didn't know this. The chance, if you do every 2-year mammogram screening from 50 to 74, on average, every woman will have 1 false positive mammogram, on average. Many will have more, some won't have one. If you do every year, it's almost 2 false positive mammos per woman. And then you can see the unnecessary biopsy rate goes, with annual screening, goes up to 1 in 4. The overdiagnosis rate is kind of minimally changed. And we see a similar thing if we say, instead of starting at age 50, we're going to start screening at age 40. These are all done for every 2 years. This is data from the USPSTF. You can see the difference in your chance of not dying from breast cancer is again small, slightly smaller. The average life years gained is exactly the same as the last one. And in this case, you do have the increase again, slightly less, in false positive mammograms, now 1.5 per every woman. Unnecessary biopsies go up to 1 in 5. Overdiagnosis does not really change. Here's some more facts I just thought were interesting that helped me in talking to women who are thinking of getting mammograms, especially in the more questionable time period, that 40 to 49. I honestly, looking at the data, I don't have a dog in the fight at all, because it's totally reasonable for me to say that is way too much diagnosis at this young age group. We should screen more. And I think it's important to know that there are risks, and it's important to know that the screening is nibbling at the edges. But if you get a mammogram age 40 to 49, 1 in 8 of those mammograms will get called back for more imaging. For every cancer we detect in that young age group, 10 women will be biopsied. And then the other thing is, if a first-degree relative has breast cancer, a very common condition, the interesting thing is the risk is exactly the same as a 50 to 59-year-old woman. So maybe that might be enough to bring them up over the edge. If your first pregnancy has been before you reached age 30, your risk is reduced. Clinical breast exams, most people probably know this, are not helpful. They have studied them with mammograms to see if it adds a little benefit. Without mammograms in places that they couldn't get mammograms, no benefit has ever been seen in a trial, a large trial. And I think if you ask me, the reason is that any woman who comes in and says, I think I feel something right here, even if I don't, it's hard to find the courage to say, no, we should never look at that again. You end up sending them, and now you've increased the false positive rate in a lot of cases. The other interesting thing I think came from the American College of Physicians, that the benefits of breast cancer screening for mortality are delayed an average of 11 years. That's what they use to say, that's why we should stop at 75, because average lifespan for women is 86. If you're thinking of going later and you've got a very healthy 75-year-old woman, I think that's very reasonable. But I think that 11-year gap between screening and benefits is an interesting thing to think about. Because then you can go, what's the chance that this woman will get into her 90s? What's the chance that she'll reach 100 and get a letter from whoever the president is? And that can help you with that decision.
So Mike, there's another question.
Yeah.
So what is the definition of false positive? Is it just a follow-up screen needed since the biopsy rate?
False positive is simply, well, false positive is after. It's a positive, it's any kind of a positive mammogram that leads to more actions that is not cancer. So it's something you say retrospectively. That's a great question. You can't say it's a false positive until you've gone down the road and you know that woman does not have cancer. Thank you. And I think that, and this is another case, the breast density, where definitions are important, because I always have made fun of the whole dense breast discussion, because one, it just seems like an insulting thing to say to anybody. And two, dense breasts are just more breasts in the breast, more breast tissue in the breast. And that's what they are. It's a radiologic term, and that's why it has a BI-RADS category. And there's the chart that shows you what they mean. And you can see the denser breasts, more breast tissue, has a slightly lower sensitivity for finding cancer. But the important thing to know is that with each mammogram, 20% of women who are either dense become not dense, or not dense become dense per the mammogram. So it's not a very reliable finding unless women's breasts are changing that fast. We have no good data of what to do with these women, yet nearly half of states mandate that radiologists tell women they have dense breasts, which just seems mean to me. They have looked at, we've got a little bit of evidence for, should we do annual screening if you've got this breast density, so you've got this lower sensitivity, and here's the data we have. From ages 50 to 74, it doesn't seem to make a difference. It doesn't improve any detection. In that younger age group, if you do annual screening, it does half the risk of an advanced cancer or half the risk of a large tumor, which we're saying is larger than 2 centimeters. The risks on the other side increase a lot. The risk of a false positive, so that's a finding that suggests cancer that is not, increased by 3 times. Look at that. Over the 10 years from 40 to 49, your risk is over 2/3 that you will have a false positive rate. And that's a lot. And then the risk of an unnecessary biopsy goes from 3% to 12%. And then overdiagnosis. So overdiagnosis, I had to, this is for me, probably not for any of you. I just had to remind myself, is a real cancer, but it's a cancer that would have never threatened the health of the person with that cancer. It's a much easier for me to think of in prostate cancer, where it's that whole more men die with prostate cancer than of it. But there is a rate in women as too with breast cancer. And you can look at that rate. It's up to 1 in 5 women. And then here's the interesting thing, because remember that graph that Jeff Leggett asked me about, the number of deaths we can prevent with mammograms is pretty low. So for every death we prevent, we're actually treating 2 to 3 women unnecessarily for cancers that were overdiagnosed, would not have had an effect on health. That's an estimate based on studies. And that's all I have on breast cancer. So basically, and that's the most data we have. So I'm going to do shorter versions of this with prostate cancer and other cancers because we have less information. So here's the numbers for prostate cancer. On the left side, it looks kind of the same. Instead of 30% of cancers like breast cancer, it's 26, so pretty darn close. Instead of 15% of deaths, it's 11%, pretty close. Lifetime, look at that. It's 1 in 7, which is almost the exact same thing we say with that 1 in 8 lifetime chance of breast cancer. But look at how it is age stratified. It's all in the mostly in the older age groups, which is one interesting thing that throws a wrench into the everyone should be screened. Unfortunately, the racial disparities we saw with breast cancer are even worse in prostate cancer. Look at that, the nearly 2 times the incidence in Black men as white men. And then it gets lower in other ethnicities. And survival is even worse. It's more than twice. But look at that survival. 5 years, 10 years, the overall survival is 98%, which also suggests that we are overdiagnosing, that by screening, we are treating people who will never get the disease. And look at this. I think this is very interesting. It doesn't matter if it's localized disease, don't worry about it. Your survival for 5 years is over 99%. If it's to lymph nodes, same thing, over 99%. But if it's metastatic, oof, it gets really bad really quick. So that's where it goes. And the average, and there's not much metastases because the average is still 98%. And here's a similar graph, again, made by me, of deaths from prostate cancer and how they go age-wise. We don't have the breakdown where PSA testing works. We just know that 4% of these deaths, the exact same percentage as breast cancer with mammogram, we can prevent using the best case scenario of the data. And we'll go in a little bit into that later. And then remember overdiagnosis. I kind of hinted at this. Overdiagnosis rates from studies are estimated to be up to half. And they go higher and higher as the age goes higher, which makes sense because you're going to more likely to die with it of something else as you get older. So I kind of feel like I've got to go briefly into the studies since there's only 3. And of these 3, only 1 showed any benefit. Unfortunately, all 3 kind of stink. So let's trudge through the stink. So the PLCO, prostate, lung, colorectal, ovarian cancer. This is an American trial. It was huge. The only problem is it was done when everybody got PSA. So their control, their no PSA group, nearly half of their people got PSA screening. And then of the intervention group, 35% more got it. They found more cancers, but they saw no benefit in mortality. That's what triggered the USPSTF to say, well, maybe we shouldn't do this. Then this European study, which is very interesting, looked at 9 different European countries. It was huge. It was bigger than PLCO. I didn't write down it was. And they saw overall a number needed to screen of 781 men to prevent 1 prostate cancer death over a 13-year period. Not a small number. In their countries, they only saw a significant reduction of mortality in the Netherlands and Sweden. They saw some trends in other countries, but neither of those were the biggest population studied. And Sweden had such a dramatic effect, I believe it was 42% drop, that it kind of seemed to drag the total up to statistical significance. Finally, there's this cluster randomized trial in the UK, 1 PSA test, enormous thing, nearly 500,000 men, but of that 500,000 men, only a third actually got the test. And then they looked out, I think it was 13 years, no change in mortality. So we don't know. That European test is our basis. Number needed to screen of almost 800. So here's the risks of PSA. So false positives are up to 24% of men who do a full course of screening. So from 55 to 70. And of them, they're going to get a biopsy. Just under half of those people will report significant pain, infection, or bleeding, and 1 in 100 will be hospitalized. And then the real thing is the true positives. Because of that survival, we're going to reduce the death in 13 years by a total of 0.13%. And we're going to get nearly a third of our men are going to have erectile dysfunction. Nearly a fifth are going to have urinary incontinence. We're going to throw in some MI, some heart failure, and some blood clots. And these are people who actually have cancer, but many of them are overdiagnosed. But we kind of talked about it, and I didn't really mention it, but it seems like for both breast cancer and prostate cancer, for Black men and Black women, it's almost a completely different cancer. Look at those percentages. Nearly twice the incidence, over twice the mortality. Unfortunately, with prostate cancer, we have really no data. The US trial that showed no benefit had 4% Black men. All the European trials, those are the other two, they never reported ethnicity that we don't know. They've looked at modeling using whatever data they could, and it suggests that there's more benefit from screening than there is in white men, and that it's probably better to start before age 55, which is interesting because that's a footnote in the USPSTF, but they didn't put it into any of their recommendations, probably because the data is so crappy. And that's all I have to say about that. We're already moving to lung cancer.
Can I ask a question, Mike, before you go on? So both for, I know for breast cancer, in terms of the Black women, they tend to have a more aggressive cancer at an earlier age. And when you talk about the statistics, and does that kind of like play a role in it? And does prostate cancer also present more aggressive at an earlier age?
You're absolutely right. But with prostate cancer, there's a little caveat on the more aggressive, because still the vast majority are not metastatic in Black men, but it does present earlier. So there is discussion whether 55 is great for everybody but Black men. Maybe men at age 50 who are Black may want to get earlier screening for prostate cancer. The problem is the data simply is not there to show any statistical. So you're looking at trend 4 and all the kind of bad medicine, bad science stuff. Does that answer your question? Sure.
Yes, thank you.
I appreciate that. Thanks. So let's talk about lung cancer. So lung cancer is the second most common cancer, men and women. Look at that. To quote Virginia Swims, you've come a long way, baby, because women have now reached men in their incidence of breast cancer incidence, and nearly that in mortality. So it is pretty much equal. Look at that between men and women, which I think is a little bit of a shift, because in med school, I specifically remember that this was a men's disease. So the numbers are pretty, the mortality is the big thing. And you've probably seen this. Look at these numbers compared to even breast cancer, which was not good. Breast cancer looks great compared to this. The overall 5-year survival, 1 in 5. Once becomes distant metastases, it's horrible. But even localized, it's not that great. You're talking 60%. And then if you've got small cell cancer, it's awful, because and part of that is you don't have the ability to do surgery. It does not help. So let's talk about the low dose CT trials. This is something where there's 2 trials, so you kind of need to get into it, because without that, you really can't talk about the stuff. Horrible cancer, low dose CT, side effects, because if you've got it, you're looking at biopsies and stuff like that. Let's talk about the trial. I don't remember what either of the trials stand for, so I want to apologize that before. But the initial USPSTF recommendation, which was sample all people age 50 to 84 with a 30-pack year history unless they've quit for 15 years, is based on this NLST trial. For 3 years, they gave these people who met that inclusion criteria, annual low dose CTs. They saw that they saw a 1 in 5 reduction in mortality over at 10 years. The 16% is because they recalculated and adjusted, and it might be slightly lower. They also saw a reduction in all-cause mortality from these folks, which is really interesting because these are people who tend to have a lot of COPD and other life-limiting diseases. Then this new trial, the Nelson trial, smaller, but took the age group lower. Instead of 55, went down to 50. And as you can see, a quarter of their population were 50 to 55-year-olds. And they took their number of pack years and took that from 30 to 20, and they saw a similar reduction in mortality from lung cancer. The study was too small to show an all-cause mortality drop. The weird thing is, during that study, they did annual CTs, but then they wanted to finish early, so they did the third one at half a year. I can't figure out why. So the criteria, and I wanted to introduce it only because it's very new from the USPSTF, is now screen people age 50 to 80 who have 20 pack years of smoking, however you want to calculate that, and then haven't quit for more than 15 years. Do it annually all that time. The change is based on that newer Nelson trial, and the advantage, the reason they're really excited about it, is it increases the candidate pool a lot, because now it increases the number of Black and Hispanic patients who are now eligible for the screening by more than 100%. It increases women by nearly 100%. Of course, the side effect of that is with the old criteria that were more restrictive, we only screened 14% of the people who were eligible. The false positive rate with screening is high, but with the new criteria, it doesn't increase that much. It now is 2.2 per person in their lifetime. So that means 2 times you're told, we found something, you might have cancer, and you've got to at least go look at somebody, maybe get a needle biopsy. Of course, with the old criteria, it was 1.9. And that's what's made this always controversial. The overdiagnosis rate is much lower compared to the 50% with prostate cancer. And that's just because it's such a brutal cancer. That to diagnose you with a cancer that would not affect your life is pretty unlikely unless you have other stuff going on. So the benefits are pretty big. Remember, we were looking at 4%, preventing 4% of breast cancer, 4% of prostate cancer, and patting ourselves on the back. Now we're preventing up to a quarter of lung cancer deaths, which is pretty impressive. They looked and said, well, what if screening people makes them think that now we're protecting them and they'll keep smoking, or if they recently quit, they'll be more likely to relapse? No, there's no sign of that. It has no long-term effects on quality of life or anxiety getting these screening tests. Obviously, it actually has a note. If they're diagnosed with cancer, that does cause short-term anxiety, as you can imagine. The radiation is something, though, in risks. Look at that. For every 13 lives saved, the estimate is that we're going to add 1 more death from radiation-induced cancer. And the false positive rate is huge. We talked about lifetime, 2.2% of people who are screened every year from 50 to 80, 2.2 times, on average, they'll get a false positive. The first scan, 1/4 of folks will get a false positive reading. Up to a smaller percent, up to just under 1%, get an unnecessary needle biopsy in their thorax. And the USPSTF is very hopeful that some new BI-RADS criteria, or they call it lung RADS, that they haven't really studied a lot, just will lessen the rate of overdiagnosis. That's all I have, unless there's questions about that, because we're going to move to colorectal. We only got 2 more left, so we're getting close. Hopefully you guys can hold on. So colorectal is something. I wanted to break that down by age, because now the question is, we know that we need to screen people who are 50 and above. And the question we're asking is, should we screen those who are 45 and above? And that's something the USPSTF just looked at. Looking at these numbers, you'd say, no, look at those deaths. Most of the deaths are in that 50 and above. It makes logical sense that we should hit that line at 50. And that's why the old recommendations were there. But look at how it goes, this exponential curve, and you can see it starts going up in the 40s. And the two things they want to change are that 45 to 49, and even more, the 50 to 54, because those are the ages where if you've just gotten your screening and we find a colon cancer, to a certain extent, we found it too late. And look at how that incidence goes based on age and the little inset in the early 50s. So that's what has had people going, we don't have great data, but maybe we should start screening people earlier. And then there's also this. I only included the incidence and mortality data from the 450 and 50 to 64, but the 65 and above looks a lot like the 50 to 64. An improvement in incidence and an improvement in mortality that's been pretty steady. But look at the under 50 folks. Increasing incidence, increasing mortality over the last 20 years. So this is another thing that's got people saying, maybe we should be screening people earlier. And here's the survival, which is a lot, I guess, more breast cancer-ish, if you look at it, or actually, sorry, not breast cancer. It's in between breast cancer and lung cancer, because it's pretty bad, but it's not horrible. Localized disease is decent. Regional gets worse. Metastatic is dismal. And you can see this is the difference between survival by stage, by age group. And the fact is the 50 to 64-year-olds do just as well as the under 50s. And then once you get above 65, it goes down. That's all I wanted to show there. It's a pretty complicated graph, and I apologize. But I stole it and couldn't change it. And here's how it goes with ethnicity. It's the same story we've heard before. The incidence and mortality in Black men and women is higher than any other group. It has gone down. I guess you could say it looks like it's gone down in parallel to, but you can't really say where it's converging. And then the chart on the right just shows how that is, with the first line being whites and the second one being black. You can see the difference. The overall is a significant difference, but most of that is in regional and distant. When it's local, it seems like the survival's about the same. So the only strong evidence we have for colon cancer screening, I think this is hilarious, is in tests we never use. FlexSig, we know that that's going to, that one FlexSig will drop mortality from colon cancer by almost a third. Annual fecal occult blood, which we don't do anymore, will drop colorectal cancer mortality by a third. And every 2 years will be a little less. So what we do now is we use FlexSig has become colonoscopy, fecal occult blood has become FIT testing, or fecal immunochemical testing. But we don't have great evidence for those. We don't have things, we have things that say they look the same for finding cancers, but we don't have a lot of mortality data. With colonoscopy, we have observational studies, a systematic review of observational studies does show an impressive 2/3 drop in cancer mortality from colonoscopies. And FIT testing in a Kaiser study, which you might have heard about, Kaiser Permanente in California, basically just sent all their patients 50 and above FIT tests in the mail and said, please return your poop. Here's, in the self-addressed stamp box. It did not have the Cologuard cute little box, but with that, they saw in the people who responded, they have their colorectal cancer mortality. And they said, which is interesting because it's quoted in USPSTF, they said every 2 years is about the same as every year, although USPSTF specifically recommends doing it every year. The great thing about FIT testing is the false negatives are very low. More than 1,000 tests to get one false negative missed cancer. Look at for fecal occult blood, out of every 1,000 tests, 182 were missed cancers. It's a completely different test, much better. But let's talk about the harms. The harms for colonoscopy, perforation, major bleeding, they're not that common. I'm sorry about the big range, but that's just different studies. But they're not that impossible either. If we send all our 50-plus-year-olds, we're all going to have patients who get perforated, patients who get major bleeding. Flex sig is much, much safer. There are European countries who are doing flex sigs because of that. Also, there are European countries where patients will do flex sigs without any sedation, so it's also a much easier procedure. There are only one harm really from FIT testing, and that's false positives. But look at how common those false positives are. Those false positives, every 11 tests, you're going to get one false positive FIT. So you're going to have a positive test, you're not going to have cancer, you're going to need a colonoscopy. So it's something to think about if you're using FIT testing to avoid colon. Tests that are limited, this is from the American College of Physicians, are FIT testing with stool DNA. This is Cologuard. With the stool DNA, they get fewer false negatives, but remember, that's not the problem with FIT testing. The problem is by combining two tests, you get more false positives. So you're sending more people to colonoscopy. We said FIT testing is 1 in 11. This is less. I haven't seen any quote of how many it is. And then you end up with a problem because we don't know how good the stool DNA is. The testing is very minimal on these test kits. So a lot of GI docs, they don't know what to do with stool DNA positive, which suggests that you've got stool DNA that suggests you've got a cancer. We did a colonoscopy, we didn't see anything. So the assumption is you probably, I'll bet what you have is you have a cancer that we can't see yet. So we're going to do colonoscopies every, let's see, is the boat paid off? Okay, every 6 months, every year, every month, right? Depending on how many. So that's there is no data to show us what to do. And then the CT colonography, it's good. Its accuracy is similar to colonoscopy, but the radiation is something. Think about the radiation data that we have from lung cancer screening. It's kind of worse with colon cancer because genitalia is in the way. If you need a colonoscopy, for me, the fact that you've got to do a second prep is enough to say, no, thank you. Incidental findings are so common, 69% of patients. So I do not recommend either of those. And this I thought was interesting. The British Medical Journal does a bunch of practice guidelines, and they did one. They all do their own systematic reviews. They looked at a cancer risk score before any screening that was developed in the UK. It looks at 15-year risk of cancer. And they said, if you are less than 3% 15-year risk, don't bother to screen. The problem is that risk score has been validated in British people, but not in Americans. So Is it useful? They see a very similar reduction in colorectal cancer mortality in their systematic review that we've seen. Colonoscopy, just about 2/3. Annual FIT testing, 59%. Flex Sig, that's every 5 years, 52%. Biannual FIT testing, 50%. So it's all pretty close and all pretty impressive. And then you can see, I put this little chart because I thought it was interesting. You can see based on what you choose, what your chance of being diagnosed is, which doesn't change much, and your chance of dying. And they only saw a significant difference in the 15-year risk of colorectal cancer mortality once you get to 3%. They said once you're at only 0.3%, that's similar to the risks of harm from the colonoscopy. And you can see what they did looking at the harms. They looked at the only harm was colonoscopy. So they modeled out what's your chance of needing a colonoscopy. Obviously, if you get colonoscopy, it's 100%. If you get FIT testing, they modeled based on your pre-existing risk, what your chance of needing a colonoscopy is, which I thought was interesting. All right, you ready for one more? That's cervical cancer, and it's going to be quicker. The numbers are much smaller. Look at that. Obviously, it's only women, but it is a small part. And that's honestly because our screening is so good. Survival, though, is crappy. Once you get it, look at that. It's basically the same as colon cancer. So preventing it is definitely important. This is an interesting thing looking at age and incidence and mortality. And this is based on the American Cancer Society. It's from their new guidelines. And the real issue is look at how uncommon it is in women under 30. Because what we're going to talk about is should we stick with the old version of if you're under 30, we'll do PAPs every 3 years and we'll only do cytology. And if you're over 30, we'll do co-testing. Or should we do what the American Cancer Society is recommending, which is don't do anything until she reaches 25, then just do primary HPV testing. And here's the modeling that compares them. So ACOG is what we normally do. The American Cancer Society is the new recommendations. This is all modeling studies. Look at no screening, how much higher how much more common this cancer would be. But the cancer deaths are equivalent, and with no screening, they would be magnitudes higher. The real difference overall is looking at the number of pelvic exams for PAPs that a woman would need. Her lifetime average pelvic exams goes down by nearly half, which is not nothing, according to most women I've talked to. And their colonoscopies go up slightly. The average is 1.5 per woman with ACOG, and it goes to almost 2 per woman with American Cancer Society. And as we all know, that is not equally distributed. We've got women who get 6 colposcopies and many women who get none. What's the benefit of starting at age 25? One, we don't do cytology anymore. And the problem with cytology, especially in young people, is that most of the changes in the cells are from low risk HPV. And with vaccination, that's becoming more and more common because we're moving the HPV rates to the low risk variants. So these are variants that will not cause cancer. They still cause cytological changes we can see. And then as soon as you're co-testing, it's just like the FIT testing with stool DNA. You've got 2 tests. You got false positives from one, false positive from the other. Since either one can make you positive, you're adding their false positives. Observational studies suggest that screening young women does not help reduce cancer. And also, the other thing is it reduces unnecessary colposcopies in younger women, which is important because some portion of those will go into unnecessary cone biopsies or LEEPs, which removes a significant portion of the cervix, and as we all know, is tied to preterm birth. they don't talk about, they haven't modeled how much of that, it's just something they bring up. The risks, and these are all from the American College of ACOG, American College of Obstetrics and Gynecology, that came back with a response to American Cancer, and this is their concern. They say this is going to increase our disparities. There's a higher burden of cervical cancer we're talking about now in minorities, in minority women. Minority women are unrepresented in trials. And cervical cancer is the second most lethal cancer in those under 30. Interestingly, there's a couple things that I just wanted to bring up. One is that recent data shows that Black and Hispanic women, even though they're unrepresented in trials, they're actually more likely by about 5% to have the HPV vaccinations. In white women, it's about 50%, and it's about 55 to 60 in Black and Hispanic women. And then that second most lethal cancer thing, I calculated how many women under 30 get cervical cancer, and or die of cervical cancer, excuse me, because they talked about the lethality. That's 130 women, which is a little shocking to me, only because right now, today, COVID is very well controlled, but 3 times that number of people are going to die from COVID today. The other concern is the concern that has been brought up every time when we change these things, that we're going to decrease adherence, that the way to get women to do their testing is to make it a regular thing that they don't think about. You can decide how you feel about that. And then obviously, is that adherence issue more of an issue in minorities and those with reduced access to healthcare? That's a theoretical argument, and I'll let you decide how you feel about it. So this is my final slide. What's the most efficacious screening we do? I guess by numbers, it's cervical cancer because it's so darn successful. But if you look at the other numbers, maybe it's colorectal cancer because it's such a prevalent cancer, such a high mortality, but then we can reduce it so much. So I'll let you decide. And that's all I have, pending your questions.
Thank you, Mike. Anybody have any questions? You can put it in the chat or unmute yourself and ask the question. I guess I'll get started, Mike. Throughout all these cancers, we saw that the incidence and mortality is higher among Black individuals, men and women. Do you see discussions up to why in terms of what's going on? Are they not getting screened, early? What's going on there?
There is a discussion of that. It's definitely an element of that where it's reductions in access, reductions in screening, but there also seems to be other things, and nobody knows how much of one or the other. The problem is really that all our trial data is way too biased towards the Caucasian part of the population. So we've got some evidence that we've got different versions of cancer. I didn't mention, but colorectal cancer is very similar. The rates of early diagnosis of colorectal cancer, that these cancers seem to present differently in Black populations, but unfortunately the percentage of trial participants who are African American is very low. So
thank you.
Sure.
Any other questions from anyone else? Okay, looks like nobody has any other questions. I will put evaluation in the chat box. So after we're done here, please follow the link and complete evaluation for the talk today. Thank you, Mike, for the great presentation.
Well, thank you everybody for coming.
Yeah, thank you everyone for participating. Our next grand round is going to be on July 14th. So look out for email coming from me on that. With that, we'll end. And I guess if you have any other questions later on, maybe you can email Mike to get some answers.